Hello, friends. I'll be giving an overview on this important topic, breakthrough research in onco-intensive care. It's quite a huge topic, so this I had to give as a keynote lecture in Coimbatore on 2nd November. So when I looked into this topic, so obviously I had to ascertain as to what are the key articles that have come out in last 5 to 6 years, which has showing difference in outcome in these onco-intensive care patients. So if you look at it, the whole concept of oncology is moving from what we considered at one point of time as futility to recoverable critical illness. So this is where the whole paradigm is changing. Uh, so the studies have shown that for increasing the survival, there are certain new evolving things that are happening. So the key aspect or the key dimension, which is improving the survival of these patients, is the immune therapy. So this is something that is making a difference into outcome of the patients. And the second important aspect is precision treatment or targeted therapy. So I'm sure this is a buzzword every intensivist is hearing. So having medications or having targeted sort of a therapy is shown to improve the survival. And this is an important area which is still not evolved in India. So this is the future of oncology and maybe onco intensive care also is CAR T cell therapy. So this is a T cell and this is the chimeric antigen. So this is a modified or re-engineered T cells, which call it as CAR T cells. I'll possibly make a separate video on that. So these are the three important dimensions which have shown to improve survival in oncology. And as an intensivist, we need to be adept and need to be aware of the new toxicity that we are witnessing following the usage of chemotherapy and immune therapy or targeted therapy drugs. So it has its own spectrum of toxicology they manifest with, and that is something as intensivists we need to be aware. And we need to be cognizant of the presentation to ICU, whether there is any targeted rescue therapy that we can adopt, which is more precision in direction or precision directed rescue therapy in these patients. So when you look at the breakthrough in research of onco-intensive care, I look at it into 5 dimensions. So one important dimension is the cytokine release syndrome, CRS, what we call, is something that manifests as part of immune therapy or maybe certain drug therapy. And specifically, it is shown to manifest with CAR T cell therapy, which is the future. So cytokine release syndrome is something that manifests in many patients who get CAR T cell therapy. And there are unique spectrum of problem that tends to happen with this immune therapy, which we can put it as checkpoint inhibitor pneumonitis or immune therapy inflammation, so on and so forth. So these are the names that have been coined where we use this check, which we can call it as CAP, checkpoint inhibitor pneumonitis or immune therapy inflammation. So any of these terminologies you can use. And the positioning of drugs for this, which are mainly the steroids and interleukin-6 receptor antagonist like tocilizumab, which we have used, or anakinra. So these are some of the agents that have been positioned for treating this condition. So the second important breakthrough that we need to be cognizant of is the CAR T cell therapy. So simplistically, these are the T cells which are re-engineered with the chimeric antigen. So they go and specifically target these cancer cells. The yellow one is the cancer cells. So it is a target specific sort of a therapy with this re-engineered T cells with the chimeric antigen. So that is the whole science behind it. And CAR T cell therapy invariably puts someone at a risk for CRS, which is cytokine release syndrome. And the CAR T cell therapy has shown to have some hope for refractory malignancy to take them to some sort of a curative potential. And when these patients are administered with these advanced therapies like immune therapy, ICU preparedness should be there, and ICU protocol should be put in place to manage these conditions, the toxicities of these therapies or cytokine release syndrome. And multimodal neuromonitoring also is needed because many of these CAR T cell therapy have present with unique sort of a neurological manifestation. So these are some things which intensivists should be adapted to. So the third dimensions that one could look at is organomics. So organomics simply means having a projection of possible organ dysfunction, having a trajectory of possible organ dysfunctions that can manifest with the cancer therapy or with the cancer. and phenotyping of sepsis, which I'm sure every intensivist is hearing, whether it's hyperinflammatory state, hypoinflammatory state, or a immune paralysis, or compensated anti-inflammatory response. So different phenotyping will help us prognosticate. So the fourth dimension, which I'll pay more attention to, if you look into the research papers in last 10 years, most papers are pointing towards AI and its role in oncology. So artificial intelligence with predictive analytics is going to really revolutionize the way that we look at healthcare domain, at least in onco or even in intensive care. And the fifth dimension, most important, is the extension of the organ support measures. So obviously AI is used for early detection prediction, and yeah, and the advances in the organ support measures, more so ECMO. So people are looking at positioning ECMO in certain conditions like leukemia and stem cell therapy. So this is something that is evolving. So these are five dimensions which are making sort of a buzz or noise in onco intensive care. So now before we jump into all the recent research papers, we need to understand what is the sort of prognosis? Have we really evolved? Why do we need this breakthrough? Have we really moved towards having favorable recovery in this onco patients? That comes from this very good paper where they have looked at 11 years of oncology as to how patients are behaving, whether there has been any improvement in the outcome over last 11 years in the onco intensive care settings. So as I said, in oncology, we use immune therapy, targeted therapy. We assume that it should improve prognosis. Of course, they come with their set of toxic complications. So this was a study over 12 years where they have looked at unplanned ICU admission for specific reason or non-specific reason, or admissions due to immune therapy or due to certain interventions. So they looked into all this. So in this particular study, they looked at 1,525 patients with solid organ tumors, and most solid organ tumors that they have evaluated in this particular study over 11 years are lung malignancy and the GI malignancy. So the background is this anti-tumor immunosurveillance has led to targeted actionable sort of onco mutations and targeted therapy and immune therapy. So here, when you look at it, it is shown that 1 in 7 or 1/7 of critically ill patients do have some sort of a solid organ tumor. So this is a reference study, and 40% of them tend to have metastasis. So if you look into the data of this particular study, 8.8% of the patients present to ICU with metastasis and 3.3% were ones without metastasis. This is the sort of epidemiological pattern of cancer currently from this particular data. And in this particular study, this is a nice study where they looked at whether there is difference 10 years back and now 2017 to 18. So they looked at metastatic disease. As you see, the occurrence rate of metastatic disease has increased from 48.6% to 60.2%, and that was statistically significant. And they looked at the patients getting admitted for administering of certain chemotherapy drugs or interventions. That also has significantly increased from 2007 to 2017. But the crude severity, so what this really shows is the severity of the patients has not changed over last 10 years. And ICU survival, surprisingly, you would assume and think that with the advances in the oncology, ICU survival should have improved. But they have shown that ICU survival has not changed between 2007 and 2017. And even 1 year survival, they have shown no difference. So which is little disheartening and unsettling that even with advances in intensive care, we have not shown improvement in survival, ICU survival, or neither 1 year survival. And there are certain independent predictors of ICU mortality that is identified, which is intuitively you would agree that metastatic disease will have higher mortality or tumor progression. So these are the ones which had a higher ICU mortality. And if you look into the data, the most common cause of cancers coming to ICU were predominantly lung cancers. As you see, the mortality in lung cancer was higher, followed by the breast cancer, and that was followed by the GI cancer. So this is the epidemiological data showing higher mortality with lung, followed by breast, and followed by digestive. And as you clearly see, the metastatic cancers had higher mortality as compared to localized or advanced sort of a locally advanced sort of a tumor. And this is again mortality, as you see, it's the same thing, lung followed by skin followed by digestive. And this is also mortality was high in the metastatic disease. So they looked at independent predictors of ICU mortality. Again, patients, onco patients coming with organ failure, needing NIV or mechanical ventilation had higher mortality. And patients coming with these complications with organ failure, needing vasopressors, they had a higher mortality. Someone needing RRT or higher SOFA score also had a higher mortality. So again, this is fairly intuitive to intensivists that these are the subgroup of patients who would have higher mortality. And 1 year mortality also is higher in metastatic disease or patients coming with complications who are foregoing life-sustaining therapy and cancers which have progressed despite on treatment. The tumor progression led to higher mortality. So these are some of the indicators of patients with higher mortality in patients with solid organ tumors. So what has been shown is despite increase in the oncology burden in ICU, the short-term survival and 1 year survival has not improved. So that is the problem statement we have. So the occurrence of or the prevalence or incidence of cancers in ICU have definitely increased as per the study, but the short-term and 1 year survival has not changed over last 10 years. And even with the presence of organ failure support, there has been no change. That is also something which is disheartening. And there is increased prevalence of metastasis and the increased proportion of patients who are given targeted therapy or immune therapy. Again, even with that, there is increased prevalence of metastasis. So, and there are certain meta-analysis which showed the ICU care has improved short-term prognosis in SOT, but long-term outcomes have not changed. So this is a little disheartening from this study that despite advances on intensive care, we are not able to change the long-term outcome of these patients. That's why we need sort of a more data points to indicate to us what are the things that can make a difference to these patients. And determinants of ICU outcome is extent of organ failure, type and stage of cancer, and the complications associated with the cancer. And the progression of the cancer leads to worse prognosis, be it short term or long term. The progression of the cancer leads to worse prognosis. And it is been shown. So, malignancies or cancers presenting with a compressive effect. So, any cancers having compression of vessels, they have worse prognosis. So, of course, the limitation of this study was single center. It was a retrospective study. Everybody knew the functional status of the patients. So, the conclusions of this study was advanced and metastatic cancers, three-fourths of them survive the ICU, but only one-third become alive at the end of 1 year. And even advances, there have been advances in the management and prognosis of SOT, but long-term survival has not changed. So that's the setting. That's the setting as to, despite the advances in our intensive care, we are not able to influence a great survival, at least long-term survival. At least short-term survival is something we have influenced, but not the long-term. So now looking at what is it that is making a difference to the outcome. So I have reviewed around 92 studies have come, friends, in last maybe 6 to 7 years. 92 studies have come. They have looked into 5 dimensions. So one thing they have looked is treatment protocol efficacy. So what they say is having a protocolized approach to the management has changed the outcomes. So there are these 15 studies. The references have given a few of studies, 15 studies which have shown improvement in the patient survival and clinical outcome if AI algorithms have been used to navigate the management of these cancers with personalized treatment and advanced organ support like ECMO and tele-ICU. So time and again, these 92 papers that has been reviewed over 6 to 7 years point towards three things. Three things is you have AI incorporation, then you have tele-ICU and advanced imaging. These are the three in an integrated way has shown to improve the outcome. And even oncological emergency, early detection of the emergency and timely intervention has shown to improve the outcome. So if you delay in recognizing the oncological emergency early on, we may fail to save the life of the patient. This is also terribly important. Trying to pick up early signs of deterioration, improve the outcome, and trying to identify specific phenotypes and risk factors and tailoring the treatment protocols has also shown to improve the outcome. So this is what these 15 studies have shown. And The second important dimension is technology integration levels. So as I said, there are three integrations they have looked at. One is tele-ICU, AI, and advanced imaging. So there are 20 studies which have looked at integration of AI, telemedicine, and advanced imaging, and incorporating them into the patient managed care pathways has shown to enhance the diagnosis and treatment precision. And even the telemedicine with data analytics has helped to make good decision making in this oncology in improving the outcome. And this is from these two French studies. So as you see, if you look into the literature of breakthroughs in onco-intensive care, it is all to do with utilizing AI, algorithms, and telemedicine and advanced imaging, integrating it effectively in the patient management pathway has shown to improve the outcome. It is not a drug that has helped in influencing the outcome. And this is very interesting, friends. I'm sure for all the DRNB, they may ask this question, digital twinning. So there is an entity called digital twinning and large language models. LLM is the large language models. So digital twinning is where you have a patient. So this is a normal patient, physiological patient. So this is the digital mapping of the patient. So in the digital mapping, basically you put in all the variables, the physiological variables of the patients, the lab variables, and all the imaging variables. So there is a digital footprint that is created, which helps to create the trajectory of possible prognosis and possible treatment interventions that needs to be put in place. So the digital twinning along with large language models has shown to improve the outcome. So this is the advances and this is the way forward of looking at the cancer patients. The third dimension is diagnostic and monitoring accuracy. There are 18 studies again talking about incorporation of AI with advanced imaging has shown to improve the sensitivity and specificity in oncologic emergency and monitoring the response. And AI along with the telemedicine has shown to again has shown to increase the accuracy of symptom detection and severity classification. Despite all this, there are challenges that remain with regards to infection detection. So that is the third component. Again, integration of AI with advanced imaging with tele-ICU has shown to improve the detection and precision sort of a management. The fourth dimension is multidisciplinary collaboration impact. So the studies have shown there are 22 studies which have shown multidisciplinary team approach with oncologists, intensivists, nursing, and ancillary medical staff has shown to optimize the clinical outcome. And having tumor board to collaborate. Right now we have tumor board, not necessarily ICU collaboration happens on a real time. So these studies have shown tumor board in collaboration with ICU has shown to improve treatment customization and has shown to improve the decision making. And AI integration into the clinical management pathways has shown to enhance the communication and improve the shared decision making. So again, 22 studies reinforces the team approach with a collaborative sort of an effort in improving the outcome. So the fifth dimension is ethical and implementation readiness. So 17 studies have looked at ethical consideration, which is predominantly data privacy, because there is so much of digital twinning that we do, putting in all the variables and inputs on maintaining the data sets for a patient. So digital privacy becomes important, whether clinically it is accepted, and having certain regulatory governance of these data set points with this advanced technology that are being incorporated is something that needs to have a ethical sort of an overview. And challenges still remain to maintain the algorithmic transparency. So, and how well we are maintaining the transparency of the algorithms put in place to manage these cancer patients, and having whether there is an equitable access to these innovative means to save a life or to treat these cancer patients is something that is there. And there has to be efforts put in to mitigate the biases. So these are some of the challenges. So AI algorithms or AI incorporation with the tele-ICU has been largely accepted by the patients and by the clinician, but it needs validation and clinical governance. So if you look into all the breakthrough research papers over last maybe 6 to 7 years, you will get around 100 papers, but most of them talk about these 5 dimensions, friends. So this is something very important. So now I will move to the clinical conundrum. So what we did is We put in brief the sort of breakthroughs that are happening. Then we spoke about the clinical context that over 10 years, where nothing has changed with regards to improving the outcomes, long-term outcome of these patients. And the third thing, we looked into last 100 papers in last 5 to 6 years, what they predominantly emphasize on. And we'll just talk about one complication, which is all the immune sort of a immunotherapy that we subject these patients to. They have these unique complications called immune checkpoint inhibitor pneumonitis or immune inhibitor inflammation. So that is something we need to be aware of. So there's a lot of immune therapy drugs that are being used in cancers like nivolumab, pembrolizumab. So this is a T cells which basically manifest with programmed PD1 is programmed death 1 receptors. So, and there is this tumor one which manifests with this PDL1 ligand. So, all this immune therapy, they act on programmed death 1 receptor, or there are these immune therapy drugs which act on programmed death ligand L1. And there is this other immune therapy class of drugs called ipilimumab, which acts on cytotoxic T lymphocyte A4. So, these are all immune therapy which acts on immune receptors. And anti-PD1 and PDL1 response is what is looked at as a effective immune therapy. This leads to activation of the T lymphocytes. So this is activated T lymphocytes putting up all the receptors. This improves the cytotoxic function and helps in the apoptosis of the tumor cells. So this is the mechanism of action of immune therapy. Basically, we only have to remember they act on programmed death ligand and programmed death 1 receptor and cytotoxic lymphocyte A4 antigen. So they act on that and cause apoptosis. So that's the way they work. But why it is important? Because all these immune therapy drugs are used for various cancers interchangeably. So they're used in colorectal, melanoma, lung cancer, so on and so forth. But these checkpoint inhibitors, when you use, they lead to certain characteristic signs and symptoms which can affect the lungs and multiple other organs and lead to various problems. So when we attribute a lung problem, so typically you would know when they give immune therapy, these patients may get breathless, they come to ICU. The first thing you'll think is whether there is infection or whether there is tumor progression. Obviously, you have to rule this out before we call them as checkpoint inhibitor pneumonitis. The incidence of this is 3 to 5%. So IRAEs is immune-related adverse events. The mortality attributed to the immune-related adverse events is 0.45%, and out of which checkpoint inhibitor pneumonitis constitutes around 28%. And immune-related adverse events is shown to occur at 90% of the time when patients are on cytotoxic lymphocyte A, sort of immune mediators, and 70% of someone who are on PD1 and PDL1 inhibitors. And they tend to occur within 12 weeks to 1 year during the induction phase. So what are the characteristic feature of this immune therapy related side effects? They can affect every organ in the body. So they can have neuropathy, they can present with myasthenia, demyelinating condition, they can have uveitis, and they can have endocrine problems like hypothyroidism, hyperthyroidism, adrenal insufficiency. They can present with inflammation of the lung, ILD. They can present with hepatitis. They can present with GI inflammation, myocarditis. So all itis, all inflammation of any organ in the body. So they can manifest with arthritis or colitis and nephritis. And dermatologically, they can present with dermatitis, erythema, vitiligo, alopecia. So any of these conditions can be characteristic feature of immune-related adverse events or all the immunotherapy agents that one uses. So there are certain risk factors for checkpoint inhibitor pneumonitis. Gender is one of them. Old age are more vulnerable for checkpoint inhibitor, and smoking is a risk factor. Someone who has received a radiotherapy before or who have an underlying ILD are at a much higher risk of developing immune-related adverse events. And there is a grading of checkpoint inhibitor pneumonitis. The pembrolizumab, which is PD, which is programmed death receptor inhibitor, the incidence is 5.64%. PD1 and PDL1 causes 3.25%. The CTLA4, along with this program cell death, has a higher risk of checkpoint inhibitor pneumonitis. And the timeline, so when they are on this immune therapy, these sort of manifestations which I showed you can occur anywhere from 9 days to 19 months. It's not immediate. So these patients can manifest with these problems even up to more than a year. So that is something we need to be aware. but the median timelines within which they manifest with these are 2.8 months. So the clinical manifestations is very subtle. They can feel malaise, fatigue, unwell, cough, fever, and they can have Velcro crackles. They can present with acute, subacute, chronic, or occult. Labs, they'll have high counts, CRP will be high, ESR will be high. PET can be non-specific. Bronchoscopy with biopsy can be confirmatory in this. So differential diagnosis, this is a very important slide. So any cancer patients who come to ICU, either they come with only two things. Either they come with short of breath or they come with hemodynamic compromise. When they come with short of breath, you have to have around 6 differentials, which I have coined acronym or a mnemonic rather, which is called WIT CLE. So V stands for venous thromboembolism is something that they can come with. So, and edema, they can come with edema or hemorrhage, pulmonary hemorrhage, and L stands for lymphangitis or lymphangitis carcinomatosa. And they can have radiation sort of a inflammation that can have, and they can have tumor progression or infection. So this you can put it as with CLE. V stands for veno-occlusive, I stands for infection, T stands for tumor progression, C stands for checkpoint inhibitor pneumonitis, L stands for lymphangitis, E stands for edema or pulmonary hemorrhage. So it's a very simple mnemonic for you to remember. Any patients with oncology who come to ICU with SOB, at least look into these categories to try to ascertain what are the possibilities of so lymphangitis carcinomatosa is a common thing that can happen in adenocarcinomas, RCC, so on and so forth. So when you look at the categorization of this, National Cancer Institute grading has categorized these immune-related adverse events as grade 1, which is asymptomatic. Grade 2 is they become symptomatic after the administration of the drugs. Grade 3 is there is limitation of activities of daily living and they're oxygen dependent. Grade 4 is where they require advanced sort of an oxygenation measures like NIV, HFNO, or intubation. So these are the categorizations as per the National Cancer Institute grading. And grade 5 is death. So pneumonitis patterns. So these are the studies which are shown that organizing pneumonia constitutes around 23%, hypersensitivity pneumonia constitutes around 16%, and non-specific interstitial pneumonia around 8%, bronchiolitis 6%. So this was another study from US which said the immune-related adverse events or checkpoint inhibitor pneumonitis, 19% can have organizing pneumonia, 7% can have hypersensitivity, and NSIP, which is non-specific interstitial pneumonia, 22%, ground glassing in 37%, and unclassified. But generally, when oncology patients come with SOB, the typical finding we tend to see more often is the GQOs. That is the commonest sort of a feature. So organizing ammonia, so you'll have a features like this. There is a ground glassing opacities more in the lower lung, and there is no subpleural scarring can be there, and there is a reversed halo and atoll sign. Non-specific interstitial pneumonia, they have symmetric ground glass opacities and they can have reticular pattern, but they do not have subpleural scarring. So subpleural scarring was seen in this organizing pneumonia. This is not seen in non-specific interstitial pneumonia. Hypersensitivity pneumonia, they have ground glass opacities more in the mid and upper lobe, and they can have air trapping. And acute interstitial pneumonia, which typically we tend to see in ICU, they present with ARDS and more profound sort of a opacities that you see, and we call it as a crazy paving pattern, and they can have septal thickening. And bronchiolitis, so you can have tree on bud sort of an appearance in bronchiolitis, and so they have centrilobule nodules, tree in bud, and they can have consolidation. So this is the bronchiolitic features. And there's something called radiation recall. Again, they have ground glass opacities. And so this is for radiologists to ascertain. But essentially, remember, the CT findings are typically ground glass opacities. Septal thickening can be there and some sort of a crazy paving pattern, trion, but more like ARDS they tend to present. So when you talk about immune therapy, sort of an inflammation, so it is shown that immune therapy related pneumonitis or checkpoint inhibitors tend to occur with more severity, more extensive, and there is increased risk with high grade and higher severity and multi-organ involvement. But the conventional chemotherapy is more dose dependent. So when you look at American Society of Clinical Oncology with regards to treatment of this checkpoint inhibitor pneumonitis, grade 1 is hold the immunotherapy, and follow up with CT after 3 to 4 weeks. Grade 2 is hold the immunotherapy and give glucocorticoids. GCS is glucocorticoids and taper over 4 to 6 weeks, and empirical antibiotics could be considered, and monitor imaging every 3 days. Grade 3 to 4, you have to stop immune therapy and give glucocorticoids and taper over 4 to 6 weeks with empiric antibiotics, and they may need hospitalization. So simplistically, the treatment of choice is to stop immune therapy and give steroids. And the steroids dosage is 1 to 2 milligram per kg per day for 6 to 8 weeks. And it should not be generally continued for more than 12 weeks. And any patients who has got steroid of 20 mg for more than 6 weeks should be covered for PCP prophylaxis. And if they present with respiratory failure, they should be treated for PCP. And 70 to 80% of them are controlled. So prognosis and recurrence. So grade 1 and 2, all our patients tend to resolve. Grade 3, 64% of them resolve. The rest of them possibly will die, and recurrence can happen in 1/4 of the patients. And retreatment, even if you retreat, there can be recurrence of this checkpoint inhibitor pneumonitis in 17 to 29%. If patients go into refractory sort of immune therapy pneumonitis, then IVIG 20 grams for 3 days is considered, followed by IVIG or IVIG 10 grams once a day for 5 days. So in very refractory cases, they have combined corticosteroids with tocilizumab, and they have shown 80% response. And mycophenolate mofetil and pulse dose methylprednisolone also could be used as a sort of a desperate measure. So all in all, friends, so this is a unique set of problem which every intensivist should know, which is immune therapy related organ dysfunction or pneumonitis. So one has to recognize, one needs to have a clarity on differentials. Treatment essentially steroids. In refractory, you have to think of giving IVIG or other immunosuppressants. So the conclusions of this is checkpoint inhibitor pneumonitis or immune therapy related uh, inflammation. It is a combination of clinical, radiological, and history. It can be fatal, and steroids controls most, and that is something we need to aware. So if I had to summarize this whole breakthrough research and conclusion, so this is the first conclusion. The clinical sort of a breakthrough is the unique set of problems related to therapy, which is cytokine storm, which I have not covered in this. I've spoken more about immune therapy related organ dysfunction and CAR T cell therapy and organomics, phenotypes, AI, and advanced organ support. And other breakthrough is having treatment protocol in efficacy, which has shown to improve the survival. And there are 20 studies, as I said, which has looked into integration of AI, telemedicine, and advanced imaging as to making a difference to the outcome. And 18 studies which has looked into diagnostic and monitoring accuracy, which happens with the integration of AI and advanced imaging shown to improve sensitivity and specificity. And the fourth dimension is multidisciplinary collaborative effort between oncologists, intensivists, nursing, shown to improve the outcome. And the fifth dimension is looking into data privacy, clinical acceptance, and regulatory governance. So this is all the breakthrough that I could come across. So it's quite an exhaustive topic, but those are the key elements that you can keep in mind. So thank you one and all. So you can request you to submit valuable work to Journal of Acute Care. First, you can visit my website to read to this lecture. Thank you. Thank you one and all.